We've got a lot to squeeze into this next hour, a lot of information, a lot of people to hear from. So I think we should carry on, and I think more people will join us during my introduction. So thank you for investing your time in coming along today, and I want to make sure that you get the best from that investment in time. I really appreciate how busy everybody is at the moment. A lot of referrals coming through emergencies, through A&Es that were elective. We've got a backlog of patients that are starting to wash through as well. And I think that this makes the timing of this particular webinar on protecting yourself and your team even more relevant as that workload really concentrates over the coming months. And really importantly, to make sure that even though your lab and your X-ray environment is going to be really busy, you take the time out to look after yourself and reduce the exposure for yourselves and your colleagues. And just to make sure you keep fit and healthy and doing the great job you're doing, this is part of that, is looking after yourself. We often put the patient first, and there's nothing wrong with that, but you've got to take the time out to look after yourselves as well. We know that using X-rays, it does give the effect of generating scatter radiation, exposing the operators to small amounts of radiation over a long period of time. We're in the business of helping reducing those doses, primarily through the products that we supply, but also I'm a big believer that we can reduce around about 20% of your exposure to radiation just by education. And that's really the purpose of what we're trying to achieve over the next hour. We do have a couple of promotions around our aprons, and also for free draw, which when you registered, you got the option to opt in or opt out for our Radpad shields as well. This is going to be recorded, as you'll have noticed when you logged in, you had to consent to being part of the recording. And that's really to give people who are busy and don't have the opportunity this afternoon to watch this seminar back in the future. We've got question and answers. So if you scroll down to the bottom of your page, you'll see the options come up. There's Q&A and numbers of participants, etc., etc. So please put your questions into that Q&A box. We may be able to answer them as we go through the course of the presentation, but we do have a section at the end for addressing those questions directly from our speakers towards the end of the presentations. On that note, we have three great speakers today, and they've all given up their time, not just for this, but they've also done the preparation as well. We have Dr. Bella Huasen, who's based up in Preston. Let me just consult my notes here, Bella, while I get it right for you. Bella is an endovascular and interventional radiology consultant in Lancashire University Teaching Hospitals in Preston, and she's committed to education and development and leads the IR research with an avid interest in radiation protection. And Bella will be presenting on radiation protection and image-guided therapy. So Bella, if you're ready to do your presentation, I will hand over to you, and I'll introduce the other two speakers in more depth as we come back to them. Thank you, Bella.
Thank you, Stephen. Thank you, everybody, for having me on today. I will try and focus on some of the image-guided therapy and leave the endovascular component for my colleague later on. So I think Hannah or Lucy in the background is okay to move on to the next screen. So I think for most of us, whether you are an IR, endovascular, or angiologist, depending on the country that you practice, you will come one way or another towards radiation. This also includes our spinal team, orthopedic. It's become inevitable that in your clinical practice, one way or another, you will now practice some form of clinical procedure that involves radiation. It is a less sexy topic. We don't often discuss it. We don't often acknowledge it as much as we should. We definitely by far talk about all the latest gadgets, especially for those of you that deal with endovascular, a component that's always evolving with fancy tools, especially if you deal with CLI. We will talk all about all the fancy balloons, wires, techniques, but not often would you find us clustered discussing what is your latest way of protecting yourself from radiation. Do you really wear those goggles? Are they comfortable? Are they not? It's not a conversation we often have. And it is alarming. I would say that for most of us, especially for those of you that are under the NHS, we are committed to a long service. I would say the minimum most of us will be serving is at least 25 years of consultancy. And therefore that is a long radiation exposure time. And if you do not protect yourself early on, that accumulation will inevitably affect you one way or another. And again, we have to bear in mind the data and the research that we focus on and use. Next slide, please. So if we go into the non-vascular procedures, there are a lot. I'm just going to focus on the main ones that do crop up, the ones that most people are interested in. TASE, CERT, these are the oncology procedures. So if you're an oncology center or you developing your oncology services, these are some of the procedures that you may want to focus on or you're already practicing. This procedure in itself has twofold of radiation issues. One, the actual product that you will be injecting into the patient has its own set of rules, and then the actual procedure. Because a lot of the times colleagues have moved on to using radial access, that poses a bit of a challenge, because where do you place your radiation shield? Where do you place yourself? Where do you place the C-arm? And then if you're going to do a 360 turn to find out exactly where your catheter tip, again, that poses another radiation. Do you stay in the room? Do you have a function where you can step out of the room and press the buzzer and do that? All these things are important and not often always considered in the business case. So when I review centers that are taking TASE into their practice, you'll see a huge amount of effort invested into the basics, but not a lot focused on where the clinician may be able to protect themselves from radiation. Then we've got other fancy procedures such as prostate artery embolization, ablation, cryoablation, and then basic bog standard procedures. And these are the CT guided biopsies and CT guided drain insertions. Now, I know, like myself and a lot of colleagues, where possible, you would try and use ultrasound guided imaging. However, as we advance and we challenge ourselves and less likely want to have operative options, we would push those limits. And usually the only way to access certain sites would be to use CT guidance. And it's become really crucial, even though the technology around CT has advanced and therefore the radiation dose to the patient with time has reduced. That does not mean it's safe for the clinician to be directly inside, pressing the button and doing the procedure without cover. Next slide, please. I'm not going to go into physics. I think a lot of us have been through physics exams or some sort of certification to be allowed to use radiation. But it's important from time to time to just remind yourself that there is the primary radiation that actually comes from a radiation source, but the one that we tend to face and the one that we expose ourselves to a lot is the scatter radiation, and that can come from various sources. But as a primary operator, that tends to come from the scatter from the patient. And as much as we always put our patient first, I find that we forget ourselves as the operator. You're no good if you've got cataracts. You're no good if you're sick and well. You can't do service to your patient or to yourself. Next slide, please. So just to go through, I mentioned FARS is one of the books that I use for my physics exam. A lot of the teaching material in there is outdated, very old, and a lot of it is actually based on nuclear data from Japan, which, as you all know, is not what we're doing. We're not going into an IR or an endovascular suite in a nuclear bomb. That's not, it's mind-boggling that most of us are statistician, evidence-based medicine clinicians, but for some reason, when it comes to radiation protection, we don't use the same logic. We don't use the same, avid interest to try and get the correct data to support what we're doing. Next slide, please. I mean, I've just got some images. These are actual tutorial videos available online for most clinicians. And the shocking thing is that these have gone through rigorous teaching processes to ensure that the material delivered is per curriculum. But what you'll find is there is no radiation protection. This is a clinician who is working directly under the C-arm. There is no lead shield there. He has got a lead gown on, but there is no there's no lead shield there. There's actually no goggles, you can't see, but he's not wearing radiation protection for his eyes. Next slide, please. Again, so it's just to, I've covered the doctors up, but it's just to show you that we're still so behind. We are teaching our juniors of how to do these procedures safely for the patient, but I think in terms of safety, we also have to consider radiation protection. There are two elements there. You can see that the doctor is actually having to stoop down, so the actual level of the bed, the C-arm is not correct for his height. There is no protection between the clinician, the patient, and the C-arm. There is no, and I do understand that a lot of the equipment that we have in most centers are not compatible with the procedures that we do. However, that does not excuse us pushing the industry to provide us with the equipment that we do, just like we do with other procedures. When I do CLI, pedal punctures, etc., we're always communicating with the industry. I need this kind of sheath, I need this, I need that. Are you able to develop it? But we don't often ask the same with the radiation protection. And there is a lot of advancements out there. We're just not always aware of it. There are new lead shields available that do cater for fistuloplasties and TASE procedures such as this one. Next slide, please. Again, clinician in doing a 360-degree, this is absolutely crazy. Or when you do SMA work, and you're having to tilt at an angle and you're literally just there. This is, it's crazy. This again is a teaching video material. It's passed through educational colleges to allow it to be published and to be used. It's almost criminal to me. So again, we really have to be careful. We really have to send the right messages. Okay, great, teach a person how to cannulate the SMA, but you have to protect yourself. Next slide, please. This is another one. This is what I call core medicine in procedures, whether you do MSK, spinal, radiology, you will one way or another do a CT guided biopsy. In this case, it's a crucial biopsy. They need a sample of what that weird lesion that was seen. But what you can see here is that the patient is getting radiation dose, inevitable because we need to get the sample. But the actual clinician doing the procedure, he's doing it directly in the CT scanner, but also the anesthetist. So not only are you radiating yourself, the patient, but you're also exposing another colleague unnecessarily in the procedure that doesn't need to be done that way. I've done many biopsies, many drains. I've never been inside the room, so it can be done. I've never delayed a procedure just because I happen to step outside the room and do the scanning. It doesn't delay it. The actual delay is getting the patient down or getting the patient back up to their ward. Next slide, please. Again, it's just to show you, this again was another teaching video. It was fantastic in terms of the actual material, how you do it, how you get the needle in, but it absolutely fails to say, I'm actually next to the source of radiation. I'm actually inside the room and I've got my anesthetist there and God knows that ODP or whoever else is there. And I'm zapping everybody while, I do this procedure. You'll often see as well with the teacher materials is that the thyroid shield may be hanging all the way here, away from the actual thyroid. It may be swinging here. You may see that the actual lead cover is not wrapped properly. It's almost used like, to keep the person warm. These things, even though they may seem minute, or if, you're a cowboy clinician, you don't care, it's really bad practice. And since we're going to be here for the long run, I think good practice should be applied the same as you would with a puncture technique, just as you would with where you insert the needle with aseptic technique. It should be just part of your normal practice. Next slide, please. Why worry? Next slide. I think this is probably one of the things that, you know, brought home the message to my department. This is a center not so far from us, and they've proved cellular DNA damage from a common procedure, EVAs. We do these day in, day out, whether it's part of a normal day case procedure or out of hours. And those that have kindly taken part in the practice have been able to give their blood samples, and that alone has shown that there is definite DNA damage. Now, imagine if we'd done that from when you start your career towards the end of your career. I mean, we don't have that, but just to show it's not the most robust study out there, but it's enough to kind of scare you and worry you. Next slide. Again, it's just, please do pull up this paper, and it's just, again, I just want to home in that DNA damage was found. It's not a case of, oh, it might be, it's definitely there and it's found. Sorry, just for the sake of time, I'm going to speed through the next slides. Next one. Again, there isn't enough data for what we tend to do and what we tend to accept. And I definitely think that the SV levels that we have been designated are not correct. I definitely think that a lot higher than what they should be. I know that with time they've been reduced slowly and slowly, in particular the eyes, and now it's almost mandatory to wear you know, eye protection. Before it wasn't, and it's scary. So you just think, well, what will happen in 2-3 years? Will they then discover that we definitely should have not been in the CT scanner doing biopsies? So I think it's definitely imperative that we do take charge and be safe, and definitely understand that these figures are incorrect. They're a lot higher than what they should be. Next slide, please. And this just to show you, these are old, outdated tables. You'll just find left, right, and center, and they're completely incorrect. And a lot of the textbooks that we are still using haven't been updated. Next slide. So what can we do? Definitely attend as many. I know they're boring. Physics is boring. Radiation protection is boring, but it's a way that you will preserve your health for the long run. Try and find out from your local rep or any meeting, what are the latest kit available. If thyroid shields are irritating for you, go ask, is there something that's you know, more compatible for you? Is there something that you can size up for your neck? Is there something that, you know, I've got staff that say, oh, I get a rash here. We've managed to find where you can put an undergarment that kind of protects that rubbing from happening. There's a lot that can be done. They're heavy, but then now the technology's evolved. You can get lighter ones. In terms of the actual lead shields that you can use, there's ones that, you know, rotate around with you. They're not just the block square. They come in different various shapes and sizes. So identify what procedures you definitely do, and speak with your local teams and your local reps to find out what they're able to provide you. And definitely always think it's not just about the patient, it's also you and your team. You're radiating the three of you. Just as much as you focus about your patient, definitely focus about yourself, because you are the one who's serving the patient. If you're well, you can do good work. If you start getting cataracts or you're becoming sick, you can't help anybody, and you definitely can't help yourself. Next slide. Sorry, that's so I'm going to give it back to you, Stephen. Eric is going to go through more of the actual physics.
Good, there we go. Just finding my unmute button. I've been at it for 18 months this, and I've still not got the hang of it. Bella, thank you very much for that. And, you know, the biggest, how do we make radiation protection sexy? How do we get that conversation going? And I think that's really important. I think that you're right. The missing it out when you're putting the business case together for new procedures or a new lab, we've got to raise that conversation and have those data-driven decisions around radiation protection. And one of the comments, one of our, was it Andy Rogers, who's a medical physicist with a big smile and an exclamation mark, physics isn't boring. I agree with him. Good, thank you for that, Bella. On to Eric. Eric Radtke, he's the Vice President at Worldwide Innovative Technologies based over in Kansas, and that's where we find him now. And Eric spent many, many years traveling the world, some of the time here in the UK with us, in a lot of different environments where radiation is used. The product that WIT manufacturer is a product called Radtke. But it's more about the studies of reducing long-term low-dose radiation doses to our practitioners is what he wants to talk about. Chronic low-dose radiation, not just cancer and cataracts. So over to you, Eric. Thank you.
Thank you, Stephen, and impressive presentation, Bella. You had a lot of points that I appreciated there. Like Stephen said, I'm with Worldwide Innovations and Technologies, and we develop RadPad radiation protection shields. So we're protecting operators and clinical teams from scatter radiation. We do this through our products, but we also do it through education and training. So I've compiled some studies that we have used. Bella made a great point. We have a lot of outdated nuclear data, outdated protection laws, outdated teaching materials. So hopefully I can bring some things that you might not have seen, some things that resonate with you, and things you can take back to your teams as well. Next slide. So just a quick look, some of you can attest to this, but over the last 40 years, healthcare professionals have seen their radiation doses increase by six-fold, 6 times increase in their dose. This could be for several reasons. One of them we see as increased number of procedures. As we perfect procedure techniques, we get to do more of them. So as a result, we get more radiation exposure. The other side of that coin is we develop new techniques, new technology. These procedures can take more time under fluoro. So the result can be more radiation to the operators. And then finally, one of the most driving factors, patient BMI is on the rise every country around the world. So more mass means more scatter. As our patients get larger, the amount of scatter radiation the operators are exposed to increases. So we have to take steps to protect ourselves. We have to use things like ALARA and time distance and shielding, which we'll touch on. But you've probably seen this in your own practice and you can relate to this. And this is what we're dealing with. Next slide. There's a lot on this slide, but the main takeaway is the biological latency of radiation-related illnesses can be up to 10 years. Bella mentioned this, and it's not going to happen tomorrow. Things aren't going to go downhill next week, but a little bit of exposure, chronic low dose, day in and day out, year after year, we're going to develop some of these issues. Just for some perspective, we have some numbers from cardiology. We have the volumes there to understand what's going on, and a career dose for a cardiologist to the head looks like about 1,000 millisieverts. We'll put that into perspective in a minute and see kind of what this does. The other takeaway from this slide is the table in the bottom right corner. It's probably no surprise that position 1 has a very high dose, position 4 as well. I always point out 4 from my nurses and techs that are pushing meds or treating patients or anesthetists. They're often on the exposed side of the table with no table skirt. They don't have a lead shield. They don't have a rad pad on that side, so they're getting a lot of radiation. The interesting point on this slide, which I use for teaching a lot, is the 3rd position. This is presumably the radiation tech. He's got the lowest dose at the table. He's the furthest from the tube. He's the furthest from the patient. We know the distance matters. This guy has the lowest doses in the room. We'll talk about that in a minute with a little perspective. Next slide, please. You've probably heard in your radiation safety trainings the risk of brain tumors, cataracts, and these are real risks. There are other conditions that are found in healthcare workers exposed to radiation that are often maybe misdiagnosed or not talked about, or maybe they just haven't gotten the awareness, publicity that some of the other illnesses like cancer and cataracts have. But all of these conditions here are linked by chronic inflammation. We'll talk a little bit about what radiation does and why it's important to manage this. Next slide, please. So we took this snippet from the Healthy Cath Lab study. We'll talk about the study in a minute. Interesting point is the hazard ratios. You can go down one column and see cataracts, for example, you're 6.7 times more likely to develop cataract working around radiation than someone who's not. That probably is not so surprising. We've talked about goggles, you've heard of this, but look at this for perspective, radiation to the brain. You have a hazard ratio of almost 6 for developing anxiety and depression. So it's right there on par with cataracts and even more risky than cancer. So this is something people aren't talking about, but many people could be dealing with, and something, this may be a genetic issue, this may be a social issue, but it should not be an issue of more radiation at work leading to this sort of neurodegenerative illness. Next slide. So chronic inflammation, this is the underlying cause, this underlying problem. Really, what does radiation do? If you ask a room full of people, you say, what about radiation? They say it's bad, we don't want it. That's right, but what does it do? Well, radiation, it causes oxidative stress in the body. Oxidative stress, everybody knows about antioxidants, anti-aging, and the properties of antioxidants. Radiation is causing oxidative stress, which is oxidation, which is aging at the cellular level. This can lead, oxidative stress can lead to chronic inflammation, can lead to vascular diseases like high blood pressure, atherosclerosis, and stroke. Chronic inflammation can also lead to neurodegenerative diseases like Alzheimer's and Parkinson's and cognitive deficit. It's like Bella said, we need you healthy. We need you in your best state to perform these procedures. If you can't see, or you can't think, or you're not in the right mind, it's no help to the patient. So if you're helping the patients, who's helping you? This slide has a bunch of studies in it. It really just rings home that the immune system takes radiation very seriously. They're the most radiosensitive cells in the body. That makes perfect sense, but that should tell us that radiation is a big deal to the body. I told you about X-ray techs having the lowest doses. This study talks about X-ray techs are found to have 5 to 8 times more activated lymphocytes than control groups. This means our techs who have the lowest doses in the room have an immune system that's elevated 5 to 8 times. Think about what's happening to the physician, the first operator, or the anesthetist who's up closer to the patient, closer to the tube. This is something we need to be aware of. Chronic inflammation is a result of oxidative stress, but radiation also disrupts the body's ability to manage inflammation. So it disrupts critical cytokines. We have numerous cytokines in the body, and we don't need to go into all of them, but 2 of them in particular are responsible for regulating inflammation, pro and anti-inflammation, and radiation just disrupts the body's ability to manage this, which puts us again into chronic inflammation. And you can go to any hospital and find a pamphlet in the lobby talking about managing inflammation for pain and other diseases. So this is really the important part, is understanding what radiation does. That it's leading to, it's causing oxidative stress and leading to chronic inflammation. Interestingly, Bella also mentioned that we're dealing with outdated training materials. A lot of the doses, allowable doses, are also outdated. So this study was just 3 years old, showed that these conditions of radiation-related illnesses are occurring at doses below allowable limits. So in Europe, where it's 20 millisieverts a year allowed, the study showed a lot of these conditions showing up at 14 millisieverts. So just because it's the safe dose doesn't necessarily mean it's a safe dose. So we're trying to keep things as close to 0 as possible, trying to reduce radiation exposure as much as possible. We don't want to challenge these limits. We don't want to prove them wrong. We know that they can be dangerous at lower levels. And then the last study we use on this teaching point is Bijan's study. Again, the DNA damage to the immune system can occur both in patients and in operators after a single procedure. What this quote doesn't do is give it justice and say the human body then repaired this DNA damage 24 hours later. The problem is most of us are going into procedures the next hour and the next day and the next week. So the body just doesn't have the ability to keep up. It's like a death by 1,000 cuts. So we're looking at the underlying problem of oxidative stress, chronic inflammation, and how that affects the brain and the vascular system. Next slide, please. The vascular system, I like to bring this up with when I'm talking with IR teams and vascular teams, because oftentimes you're treating a lot of these conditions, high blood pressure, atherosclerosis, stroke candidates. But you should also be aware that radiation exposure and chronic inflammation can lead to and cause some of these conditions. That doesn't seem like a very fair deal for healthcare providers to be treating these conditions and also subject to them. But how it works is that the radiation exposure is associated with subclinical CIMT, carotid intramedia thickening. So basically the hardening of the arteries, which leads to higher blood pressure. Good thing for us is that the endothelial cells on the inside of the vascular system are not so susceptible to radiation, but they are susceptible to inflammation. So with inflammation and chronic inflammation, endothelial cells are breaking down. This is how you get stroke risks. This is how you get vascular aging. So it's not going to happen tomorrow. I'm not saying quit your job or anything like this, but we should know, we should recognize these conditions that are related to the tools we use to treat our patients. Next slide, please. So while vascular aging is very important and a considerable topic, I really focus on radiation in the brain. We can do a lot of things, but without our brain, we're pretty hopeless. I talked about 1,000 millisievert exposure to the head for a cardiologist in a career. Some perspective, you can go on this dose ladder right there in the middle, 1,000 millisieverts. What is the effect? Cognitive deficit. Okay, what about the skull? Most people will stand up and say your skull can radiate or attenuate 40 to 70% of the radiation to your brain, and that's true. Studies will show this anywhere from 40 to 70%. So let's take the best one and say 70% of that 1,000 millisieverts is attenuated. That leaves us 300 millisieverts, which takes us to neuropsychiatric, neurophysiological, and neuroimmune dose related effects. So oxidative stress and chronic inflammation in the brain is going to lead to neurodegenerative diseases at some point. It's not going to happen today or tomorrow, but over a career of unprotected exposure to the brain, we're destined to have problems. Then down at the bottom of the ladder, what we've all heard about before, cerebrovascular pathology, brain tumor risks. We know this from radiation to the brain. Next slide, please. So here I have 3 case studies to kind of point us in the direction and support this discussion of inflammation in the brain and what it does. This first slide was really a study about oncology patients, brain tumor patients receiving radiotherapy, and a lot of our listeners are not these patients, but it is radiation to the brain. And these patients experience cognitive deficit, degrees of cognitive dysfunction. Really, this is radiation to the brain. You guys are not, most of our listeners are not brain tumor patients receiving radiotherapy, but we're receiving radiation to the brain in the lab on a daily basis. Next slide. Radiation workers. Okay, this again, a lot of our listeners are not cleaning up radioactive materials in the forest, but this study did evaluate those people, and they were not in the middle of the blast, but they spent 2 years picking up radioactive waste, and they had a chronic low dose exposure to radiation to the brain. And this study also showed that exposure to ionizing radiation is a factor in the genesis of depression. This is an interesting study because it showed a double-pronged approach impacted to the central nervous system, which we know, oxidative stress and inflammation in the brain leading to this result. But also the brain is understanding what's happening to the rest of the body. And if the rest of the body is under chronic inflammation and suffering through different diseases, the brain recognizes this and also starts to experience depression. The best example I can give of this is when you have a peripheral patient, a leg patient, and you have to amputate the leg. We try to avoid these amputations because morbidity for the patient goes up. So the brain can realize what's happening to the body. So it's getting a double effect of this radiation, oxidative stress, and inflammation in the brain. Next slide. This study is probably the most applicable. So we brought it from brain tumor patients down to radiation cleanup workers, and then finally to cath lab personnel. This is a study out of Italy just a few years ago, and they evaluated everybody from the cath lab to the gift shop, for example. And they showed that the exposed groups had significantly lower scores in delayed recall, visual short-term memory, and semantic lexical accessibility than the non-exposed group. So what does this mean? This just means that the radiation to the brain over time is having an impact on the cognitive ability. Does anyone know what semantic lexical accessibility is? This is where you have that word on the tip of your tongue, but you can't recall what it is. Hand me the whatever this is. And this may be because you were up late, maybe because you have a busy life at home, maybe in any number of things, but it should not be the radiation that you're exposed to at work that's leading to this sort of thing. And like Bella said, we need our healthcare professionals in good health. If they can't see, if they can't remember what they're doing, if they're suffering because of the tools they're using, that's not best practice for safety in medicine. Next slide. Just a graph that kind of illustrates the biological latency of some of these radiation-related illnesses. Each bar represents 5 years in the lab. You can kind of see after the first 5 years, the body's reacting, adjusting to the radiation exposure, even managing it to a degree. But after another 5, 10, and 15 years, we're losing the battle. So we talk about skin lesions, orthopedic illnesses. Everybody's going to say, yes, it's the apron. It's true, it is the apron. Wearing 25, 30 pounds of lead is a big deal, but radiation is also breaking down the body from the inside, making that lead heavier over time. Cataracts, hypertension, hypercholesterolemia, talked about these metabolic disorders. Next slide. So we have some general best practice. You might be familiar with ALARA, as low as reasonably achievable. So we're trying to keep patient doses as low as possible, which in turn keeps operator doses low. This means stepping back, stepping out of the room, using fluoro save, reducing the frame rates. Anything we can do to reduce doses to the patient is going to result in lower doses to the operators. Implementing time distance and shielding is very important. We want to limit our fluoro time. We talked about new procedures and new techniques working against us with fluoro time. We also talked about perfecting procedures and that kind of volume working against us in terms of fluoro time. Distance, Bella mentioned this, people not leaving during CT or spider shots like this. We're encouraging people to take a step back during the acquisitions, step out of the room if possible. But we can't always do this, as we know. We can't always do these, we can't do these from outside the room. So use proper shielding. Use your table skirts, use your thyroid shields, use your rad pads. Make sure that you're stopping scatter radiation down at the source. Next slide, please. So we use all of these studies to promote protection, people to use rad pad shields. We put rad pads down on the patient. They're sterile, they're non-lead. They stop and they attenuate the radiation that comes up off the patient without reflecting it back to the patient. So there's no negative harm to the patient. There's no negative impact to the environment. Only positives when you're using disposable shielding like rad pad. And there's clinical data to support this. The three biggest recommendations that we use and we see in the industry, the next slide, please, coming from the US government recommending to the FDA to include sterile shields, just like lead aprons, as mandatory protection. So if you're using them now, you know that you're in best practice. If you're not using them, you should know that they are best practice and they're recommended by the government to be included as standard protection. They use only rad pad studies for these recommendations. Next slide, please. ICRP, everybody understands the International Committee of Radiation Protection. They also cite rad pad studies stating that drapes and shields can be effective at reducing operator doses. Next slide, please. And then different groups like the SCAI, ACC, ASE, they've come out with position papers also citing rad pad clinical studies showing that these shields do reduce operator doses. This is just more support, reason, and data that operators can protect themselves, should be protecting themselves, and that users of rad pad can be assured they are protected. Next slide, please. So we don't want to scare anybody. We don't want anyone changing careers this week. You can have long, healthy careers in the lab. We just need to manage chronic low-dose radiation exposure. We need to protect our brains. We need to reduce that exposure that's causing oxidative stress and chronic inflammation. Chronic inflammation is leading to all kinds of diseases that we can avoid, or at least reduce that risk. We want to try to get to as low as possible, let's get our doses as close to zero as possible. And then make sure that we employ time, distance, and shielding to have a healthy and safe career. Next slide. I think that's it. So these are all the studies, just so you know, we're not making this up on the fly. We pulled all of these just like you can. They're all recent studies. We just want to keep everybody informed, trained, and protected. Thank you, Stephen.
Thank you, Eric. Yeah, there's a lot in there, so I'm not going to try and summarize anything, but I do like that phrase, invisible and insidious. That's it's really interesting. There's a lot of questions that came in during your presentation there, Eric, so I'm going to give you a bit of time to have a look through those, and if you can respond through the Q&A box, that would be brilliant. I think the other thing that I see here is that your clinical practice is ahead of the research in terms of the feedback as far as safety in this environment goes. So yeah, that's really interesting and to keep front of mind. So over to Bijan now to take us into the last presentation. Bijan is the Professor of Vascular Surgery at Guy's and St Thomas's. He's also a Senior Clinical Research Fellow at the British Heart Foundation. and his clinical focus has been the complex endovascular aortic repair, of which I'm sure the workload is increasing and is increasing. And that research into radiation exposure has led to him being the chair of the European Society for Vascular Surgery and their Radiation Safety Guidelines Committee. And Bijan is going to present for us as the closing presentation on how do I protect myself against occupational radiation exposure. Over to you, Bijan. Thank you.
Stephen, thank you very much. Pleasure to be here and listen to the two previous talks as well. Next slide, please. The next slide, please. Disclosures. Okay, so as a practicing vascular surgeon, my clinical workload focus is endovascular aortic repair. You can see some of the images associated with this here. So essentially, we reconstruct the aorta with stents from the inside using X-ray guidance. And some of these procedures can take up to 5 hours with multiple digital subtraction angiography runs and obviously lots of fluoroscopy. So I think that we receive very high doses as, or potentially can receive high doses as operators in this space. So some of the work that I'm going to outline is pragmatic and has come from studying radiation exposure related to these sorts of procedures. Next slide, please. This is a publication by another group, a French group, that has quantified or captured the doses that are associated with the procedures that I've just showed you in the previous slide. And you can see that over the years, whereas the doses have reduced, and with use of more modern equipment and modern protection, the doses have reduced, we are still getting reports of very high doses associated with these procedures from some centers. And you've got to think about publication bias as well. So you've got to think, well, what exposures are there out there that are not even being published? So I think we need to be cognizant of that. And this talk is framed around this. Next slide, please. So who are the key stakeholders? Radiation safety, as you know, pertains to the patient, to us. The type of imaging you use, the quality of imaging has a bearing on clinical outcome, and there are multiple stakeholders that impact radiation safety. Next, please. I thought it'd be useful to just put to you the dose limits that we work by. So you can see there, personnel, eye, whole body, and extremity doses. Interesting, the eye dose was reduced in the past few years based on what we found that eye was sensitive to. You can see how our, as personnel exposed to radiation, how our limits compare to the public, and there are no limits to the patient. But we have to justify each exposure. I thought it'd be helpful to outline some of the typical doses that healthcare workers in my hospital receive. So we did a snapshot over a week. So PCA is coronary intervention, venograms, which venograms and stenting are sort of lower limb and pelvic interventions. And then EVAR, FEVAR are the aortic interventions. So that slide that I showed you at the beginning. And look how much the dosage varies. And for the aortic work, you can receive much higher doses than some of the other procedures. So depending on what you're doing, you can really be, I think, at risk. There's no other way to put it. Next. These are, again, simulations of doses that different organs in the body can receive. The brain, the lens of the eye, left breast. When it comes to aortic repair, so those high dose procedures, these are the 3 areas that we found particularly at risk. So these aren't physical dosimetries. These are simulations based on a number of aortic repairs. So the average exposure is over a number of aortic repairs. So again, be cognizant of this. And I think the onus is on us to protect ourselves and the entire team. Next. Why is it important? I mean, I think Bella and Eric have already alluded to this. I think the concept is that if you transfer energy radiation energy to cells, you cause DNA breaks, and that induces the DNA repair pathway. And one of the signals that you're getting DNA damage is this gamma H2AX. That's an indication that your cell has received that energy, the DNAs have broken, and your cell is trying to repair it. Why is it important? Doesn't it just all get repaired? The answer is no, because some of these repairs are error prone, and that leads to chromosomal aberrations, genomic instability, and that's where the cancer risk comes from. Next. Bella alluded to this. This is our publication. I challenge her on the fact that it's not robust. I think it's very robust. It's published in Circulation, and I think the reviewers all agreed that beyond refute, when we isolated lymphocytes from us and other operators performing those aortic repairs that I showed you in the first slide, look at how the DNA damage repair pathway is induced after EVAR or endovascular aneurysm repair. If you perform an open repair, so with a scalpel and with the patient opened up, no radiation, none of these operators showed any evidence of DNA damage. So that really has brought it home to a lot of people that we need to be careful. And we have done some studies since that we're going to report on in the next few months that are even more scary, because those show, this is all acute damage, remember. We've done some studies that show evidence of chronic damage, so chronic chromosomal damage in operators that have been operating for years. And I think that will bring out even more reasons to protect ourselves. So keep an eye out for that. Next, please. I think the thing to point out is that we have safe dose limits, but our safe limits should be individualized. What's my safe limit may not be the safe limit for somebody else. And note that NASA individualizes all risk related to radiation exposure. And these are some of the parameters it uses. Next. And then from the study that I mentioned earlier that we published, we again found evidence of differential sensitivity to radiation exposure. So all of these colors are different operators. If you take their blood and you expose them to the same radiation dose, each of these operators mounts a different DNA damage response, again suggesting that our safe dose limits may vary. Next. So essentially the message is protect yourself. Your risk will vary. Don't assume radiation exposure is safe, any amount of it. Next. Okay, so some pragmatic slides about how to protect yourselves. 035 lead is good for most procedures. If you have a wraparound, you can achieve up to 0.5 millimeter of lead protection. The fit is really important around the arms. Make sure no radiation can get in. And it should reduce your exposure by up to 90%. But again, if you're not careful, don't think that lead protects you if you don't use it properly. This is a study from South Korea. At the bottom, you can see the attenuation rate is less than 90%. And if you're not using lead appropriately, it will not attenuate radiation in the same way, in the way that it should. Next slide. Somebody on the chat asked about musculoskeletal problems and the weight of lead garments. I think that's a big problem. I've got some back and leg pain, and it's there in up to 2/3 of interventional radiologists, compared with 1/4 of the general population. It can shorten your working life. Two-piece garments can offer protection because they distribute the weight. Think about lead composite, lead-free materials, but if you use lead equivalents, make sure it's properly certified and it offers you the same protection. Next slide. And not all bits of lead garment are the same. They have to be stored in the right way. They have to be in the right condition. And this is particularly important for our trainees. You know, the more senior consultants have their own lead protection that they keep in their office or on a hanger in the operating area. The trainees are often made to do with you know, the generic bits of lead protection, and these can not be as good as lead garments that are looked after. So you can see in this study, more than 60% of lead shielding had detectable surface lead. If it looked horrible and if it wasn't stored on a hanger, then it was much more likely to have surface lead. So again, think of that as healthcare workers when you're in these environments. Next. Next. Next slide, please. And you can see that there are, can you hear me? Next slide, please. There are studies that objectively quantify the fact that the lead caps offer protection. Next slide, please. I won't go through this again. My colleagues have already mentioned eye protection. Remember, lead protection, ceiling mounted lead protection is really important to reduce scatter. Next, please. Leg protection. Our study found that leg protection is very important. Next slide, please. Remember where the X-ray source is. The scatter comes from the bottom, and these are real-life studies showing the amount of exposure that you can get at the leg compared with the body. It's a lot. Next slide, please. And again, going back to that circulation study, we made our operators wear leg lead, and you can see that if you do that, it abrogates the DNA damage response. So a lot of the radiation energy that's absorbed is absorbed in the long bones of your leg, and wearing leg protection is really important. Next. And then finally, where are we? So this is the vascular world. We did this survey a while ago. You can see that the uptake of personal protection is moderate. So more than 60% wore a lead cap, quite a few wore lead goggles, less than half wore leg lead, and you can see the rest of the protection measures that colleagues take. Next, please. Okay, so in summary, I think what all three of us have outlined shows that there are biological consequences to low-dose radiation. I think that individual sensitivity may vary. Awareness, training, and education have already been alluded to, and they're mandatory in my mind. Maximal shielding, and again, Bella agreed with this in the answers to the questions that were posed in the chat. Maximal shielding is important, and I think we need to leverage the latest technology to minimize our exposure and maximize our shielding. Thank you.
Great, Bijan, that was great. You went through a heck of a lot there and some really interesting research. And you know, some of the research that you quoted there, published in 2017-16, which probably means the work that was done a little bit before then. And you know, I think the amount of work that people are doing now is a very different level to back then. So you have to extrapolate that forward and just think of the consequences that's going on right here, right now. So I'd be interested in the in more research around the volume of work that is being done at the moment. I like very practical explanations as well, Bijan, about how the garments fit. We all spend time in the labs, and it's first in, best dressed, isn't it, in the labs, the one that fits best. And if you're last in there, you get the one with the big gaping armholes, which then tempts people to do what we call the policeman stance and put their hands, I don't know whether you can see, I'm doing this on a tiny little camera, but put your hands under, which stretches all the armhole even more. So some very practical tips there. And I think we owe it to each other when we're in the labs, just to give each other a nudge and say, stop doing that, or your skirt's not right round the back there, or you're not covered over, your thyroid's slipping down a little bit. So thank you for that as well. The bit about legs, I heard something in, I think it was at Manchester Royal, about that once upon a time, X-rays were used for actual hair removal as a beauty therapy way back when, and I think that a lot of people experience below the knee hair loss as it is as maybe a perk of the job, but not really. And there are techniques, like you say, the cricket pads, as far as the individual legs, and also making sure that we got table skirts on both sides, going left or going on the right side of the patient as well. There's been lots of questions and comments in the questions and answers. And I know that Bella, who I think might be leaving us very shortly. You still with us, Bella?
Yeah, I'm still here.
Great, thank you. If you have a look at those Q&As in there, I've been trying to keep a track on them and at the same time keep one ear open for the presentations. There's quite a bit in there about education, and this is one of the reasons why we want to do what we're doing here. And I think one of the suggestions was working with the BSIR maybe at the next exhibition to do something. I certainly know, Eric, that we do things when we're at the Circe events. There's a whole little pavilion in the commercial area dedicated towards people who are providing radiation protection. But we haven't done anything yet with BSIR. So if anybody wants to connect us up with BSIR, we already do some live procedures anyway, so we're part of the organising group. I'd be very happy to do that. And I think Andy Rogers, who posted a lot of the questions, he's actually left now. But he was talking in there about the use of the RaySafe i3, and people might be already have the Philips branded version of that, which is the DoseAware. Any of the panel familiar with real-time dosimetry and how useful that might be?
Yeah, I mean, we have it in our hybrid theatre. I think it can alter your behavior, you know, on a minute-by-minute basis, because there's no substitute for visually seeing what actions are increasing your dose. Again, it takes constant education, because